Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of HealthQuest. St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I'm the executive producer and host of the show. Today, it is our pleasure to welcome Dr. James Butler. Dr. Butler is an orthopedic surgeon that uses 3D image-guided technology to perform his cases. A little bit about Dr. Butler, but let me first just say welcome to the show, Dr. Butler.
Thank you, Bruce.
So Dr. Butler, who is an orthopedic surgeon, graduated from Tulane University and has an engineering degree. And this engineering degree led you in a direction of I know you have a love of automobiles and the classics, but it also led you to learning more about the mechanics of the body.
That's right. The field of orthopedic surgery involves a lot of mechanics and a lot of science, and therefore, after finishing in engineering and going to medical school, it seemed natural for me to gravitate toward a field where I could still use some of my engineering principles in taking care of patients. Absolutely.
And so I also noticed that you are an adjunct professor at the School of Medicine?
Yes, I was a full-time associate professor at Tulane University Medical School before joining the Slidell Physicians Group and full-time practice in Slidell, Louisiana.
I would imagine in your practice, which has now spanned about 35 years, you've seen a remarkable leap in technology that's available to you as a surgeon.
Certainly. The principles and techniques that I learned when I finished my residency are now completely changed, and physicians naturally have to continue with education and meetings to learn new techniques that hopefully bring better quality and improve patient care.
Right. So today we're going to have a very, very detailed discussion about how some of this technology is applied in the field of orthopedic surgery. And so if you look at our slide that says what is image-guided orthopedic surgery, what is a good definition of that, Dr. Butler?
Image-guided spinal surgery or orthopedic surgery refers to using computers and computer assistance in order to safely insert hardware into the spine instead of doing it without that type of equipment, which means that there is some increased risk of complications or improper placement of the hardware.
So you're able to use this technology. Now, when I was doing my research on it, and Dr. Butler was very helpful in pointing me to the right areas to be able to learn more about what you do, it's sort of having a navigation system like what's in our cars today, right? And a GPS combined. What does the combination of that do for you?
Well, the combination of having real-time or live navigation allows the surgeon to insert hardware while looking at it on a monitor, so you see exactly where the hardware is at all times, instead of putting the hardware in and then perhaps having to take an x-ray or view it after it's already been inserted. So you see a live picture of the hardware and what you're doing to the spine with the accuracy of up to 1 millimeter.
This is phenomenal technology. This is state of the art. And if you go to talk about the equipment, take us through some of these pieces of equipment that we're showing the audience now and tell us what they are and what their role is in your case.
Well, many years ago when we first started using image-guided surgery, the equipment, though advantageous, was very crude. The equipment that we use now, predominantly what is called the Medtronic O-arm device, is the state-of-the-art, the best equipment on the market with regards to doing image-guided surgery. It involves using a machine called an O-arm that, when it's on the patient or in the operating room, looks like a giant O. It opens up and is placed over the patient and then communicates with cameras that are hooked to a computer, and then that allows us to look at the spine in 3D or 3 dimensions and at all times see the spine in live time or real time.
I know in some of the previous technologies in the operating room and of course throughout the different areas of the hospital, very common to see what's called a C-arm, which gives you this type of design, right? But in this O-arm, it completely surrounds the patient.
It does. It completely surrounds the patient, and whereas a C-arm is sort of a live, real-time X-ray, an O-arm is a live, real-time CAT scan, essentially, and uses far less radiation exposure to the patient.
And we did a lot of research on that. The reduction in radiation to not only the patient but to everybody that's working in that room is a significant safety enhancement for that. Now there's also some other devices that our audience can see on the screen right now. What are those?
Well, those are monitors that allow the surgeon and allow the X-ray tech who's assisting to see in real time where I am in the spine and where I'm navigating or where I'm inserting hardware or different types of probes. So there's a monitor for the X-ray tech and one or two monitors for the surgeon, and who may assist the surgeon in surgery.
And if you need to move the O-arm back and forth, who does that? Is that the X-ray tech that's moving that?
Well, the X-ray tech does that. We drape the O-arm so that it's in a sterile field, and we can at any point in time use it to help us check our placement of hardware or assist in the placement of hardware. Essentially what's done is a monitor is placed on the patient that communicates with a camera that's connected to the computer. We then take an intraoperative CAT scan of the spine and then monitor the patient and navigate off the CAT scan that's stored in the computer. If you were using fluoroscopy or a C-arm, you would have to insert the screw and then take a picture of it after you've inserted it. Or if you try to use the C-arm while you're inserting it, there's a great deal of radiation exposure to the patient as well as to the surgeon. And that's very important since over one's career as a surgeon, you may be exposed to significant amounts of radiation over the years, which increases the risk of cancer.
Absolutely. So we're going to talk about some of the advantages of this technique over some of the other techniques. And some of the advantages are, you mentioned earlier, about real-time navigation. And so real-time meaning that if you're looking on a monitor and then you actually have these devices. Now, show us where you work. This is a model of the spinal column.
Well, this is a typical model of the lower back or lumbar spine, showing the vertebra and then the disc in between and the spinal nerves. Where we insert the hardware is in close proximity or near the nerves. So the advantage of having a live picture while you're inserting the hardware reduces the risk of the screw inadvertently touching or injuring the nerve. Image guidance is also very helpful when you have abnormal anatomy. This is a picture of the normal anatomy of the spine, but sometimes patients may have had previous surgery, which changes the normal anatomy and increases the risk or the difficulty of the case. Patients may have scoliosis or problems that they're born with, where the spine is abnormally structured and things aren't where they are supposed to be as far as the anatomy of the spine.
We talked about the superior image quality. We talked about the importance of the reduction in radiation to everybody that's in the room, and of course including our patient. And if we look at complication rates, if we had to say, looking at this type of surgery versus non-image guided, what do you see in the science?
With the insertion of these screws near the spinal column and near the spinal nerves, there's a risk that the screw itself could touch or injure a nerve. Without the use of image guidance, statistics show that the chance of a screw inadvertently touching a nerve is about 5%. With the use of image guidance, which is accurate to less than 1 millimeter, it reduces the risk of a screw touching a nerve to less than 1%. So a significant reduction in the complication of inadvertent screw placement.
We also talk about the importance of reduction in surgical time. Now, the longer that a patient is under anesthesia, you have generally an increase in risk as the time goes on. Is that fair to say?
That's true.
And so how is it that this can reduce the surgical timeline?
When doing complicated surgeries and when using hardware without image guidance, a surgical case may take 4 to 5 or 6 hours time, which increases the risk to the patient of being under anesthesia for that period of time, as well as increasing the risk of blood loss and increasing the risk of infection. In other words, the longer the surgery takes, the greater the risk to the patient just because they've been under anesthesia for that period of time. My experience has been using image guidance can almost cut the surgical time in half. Not quite, but close to that. So thus you have a shorter operative time, the patient's under anesthesia for a shorter period of time. There's less blood loss and less risk of infection.
So at this point, would you take us through what you actually do as far as the hardware is concerned? Show us these different screws and devices, and we're gonna follow up this presentation with a fascinating show on a specific procedure, but called TLIF. But on this one, Dr. Butler is going to show us how it actually works and where the screws go.
Well, the patient is laying on a table, and we have the spine exposed.
Face down.
Face down, correct. The O-arm is brought onto the field and directly placed over the area where we plan to operate. A device is placed on what is called the spinous process, or the bony prominence that you can feel in your lower back if you touch your back in the middle. And that has little markers that connect to the computer. We then perform a CAT scan that takes about a minute or less while the patient is sleeping, and then move the O-arm out of the way, but still on the operative field and still sterile. Then that allows us to use various instruments to first make a hole in what's called the pedicle, which is the strongest area or portion of the spine, to place implants, and then allows us to insert this screw called a pedicle screw while watching the screw actually go into the bone in real time.
You're watching it on the monitors using the O-arm?
I'm watching it on the monitor. As the screw goes into the bone, I'm seeing it advance or go into the bone in real time. I can change the direction of the screw as it goes into the bone in real time if I need to, and it, as previously mentioned, is accurate to within 1 millimeter.
And what you're doing here is you're building an additional structure, aren't you, onto the spinal column to give support. How does this all tie together?
Well, when you are trying to perform what is called a spinal fusion, where you're trying to structurally enhance or make the spine stronger, adding hardware is like an internal brace that increases the likelihood that the bones will heal properly. Before we had the development of hardware, we would place bone graft or small pieces of bone around the spine and either put a person in a back brace or ask them to reduce their activities in order to let this heal. I think of hardware like a cast. If you broke your arm, a cast is put on the arm on the outside of the skin in order to keep the bones from moving, to improve and speed up the healing of the bone. This is like an internal brace that holds everything still and is more structurally sound than putting an external brace on as far as letting the bone heal. Hardware doesn't take the place of the bone, it just improves and increases the likelihood that the bone is going to heal faster and properly.
And Dr. Butler, that's what, when you talk about the healing, that's actually called the fusion itself? Is that what that is called when it grows back? That's
correct. The purpose of navigated spine surgery and what you hope to achieve is some type of what we'll call construct or placement where we have screws connected by a metal rod on each side of the spine Some surgeons prefer to insert only hardware on one side. Others, including myself, prefer to insert it on both sides since it's a stronger construct. But in the end, this is what you hope to achieve, and this is like an internal brace. The bone graft is placed beneath or below the hardware to connect the bones and make them grow together. Sometimes we will add, for increased stability, a device in between the disc space called a cage, similar in shape to this, and then this is actually placed between the vertebra to give added stability. So you are bracing the spine, if you will, both in the front of the spine and in the back of the spine.
In some cases, in my research, I learned that the spine, because of the disc degeneration, the spinal column will collapse or at least move closer, the vertebrae will move closer together. Is one of your objectives here to correct the distance between the vertebrae?
Yes. As we all get older, our body naturally ages, including the spine. When we're 25 years old, the disc, which acts like a cushion in between the vertebrae, has about 75% water. So I tell patients that it's sort of like a water-filled sponge and as a shock absorber. As we get older, we lose some water out of the disc, and naturally it's like letting air out of a tire of a car. The disc narrows and the vertebrae become closer together. As this occurs, you can develop what is called spinal stenosis, where the nerve that comes out on the side of the spine gets compressed, or as people say, pinched, because the disc has narrowed too far and it's now touching the nerve. When we do spinal surgery, especially a spinal fusion, we're trying to expand or separate the vertebra back to their normal state, so that helps to open up the passageway for the nerves and lessen the pressure on the nerves.
What would a patient expect before surgery? Some type of, we're going to have to do some preliminary work, aren't we, before we make the decision to actually go in and do the surgery?
Well, the most important point about spinal problems and spinal surgery is that only a small percentage of people need surgery. Approximately 80% of patients can be treated without surgery successfully. So there's only a small number of patients that actually come to having surgery. Prior to that, we utilized other conservative measures, meaning non-surgical methods such as physical therapy. We sometimes perform diagnostic tests such as MRIs or CAT scans if patients are not improving as we would expect. And we also use what is called pain management procedures. Pain management means different types of injections around the spine to either eradicate a painful structure or reduce pain from a painful structure, such as a pinched nerve or arthritis in some of the joints in the lower back. When we talk about surgery with a patient, we certainly encourage them, if they feel comfortable or if they need further opinions, to get a second opinion about the need for surgery and the type of surgery. Surgeons or individuals who can give varying opinions, and sometimes patients are confused about the type of surgery they need or the extent of the surgery. So we talk about all of those things. We try to treat a patient non-operatively, but unfortunately there's a small percentage of patients where they can't be treated non-operatively and may require surgery, or that may have to consider having surgery for their condition.
You talked about pain management as one of the treatments that your patients may go to first before they need surgery, or and pain management today, and I think what you're referencing is injections in the spinal column. Is that what you refer to as pain management?
Yes, I understand that the term pain management may be a little bit confusing to the public. What I'm referring to is a person, a medical doctor, who's been trained in different techniques to administer injections, most often to the spine, to try to alleviate or diminish a person's pain. There's a different aspect of pain management called medical pain management or medication management, where a physician tries to get a patient on an ideal regimen of medicines to address their condition, and with a minimal risk of addiction to medication.
Right. A whole lot of talk about that in the lay press right now, and so I know conservative physicians like yourself will try many different aspects, many different approaches before going on to any type of oral medical regimes. So what about recovery? A patient says, well, okay, I'm going to do this, and what should I expect in my recovery?
Well, we try to give a patient a reasonable estimate of how much time it'll take for them to recover from the surgery and to be the best that they can be. Of course, the longer or more extensive the surgery, typically the longer the recovery. Using image-guided surgery and inserting hardware speeds up the recovery and also affords the patient, in most cases, less postoperative pain. So that's important for patients to understand the pros and cons of using hardware as opposed to not using hardware. It does speed up the recovery and lessens their postoperative pain.
So if you look at doing this type of case that you talked about today, typically 4 to 8 weeks, 4 to 6 weeks generally, as far as restriction and activity, anything like that?
Usually I tell a patient that they're going to be in the hospital. They may spend 1 or 2 nights. Rarely does somebody stay in the hospital beyond that point in time. Mm-hmm. For a spinal fusion, which is essentially like a bone healing equivalent to a fracture, it will take at least 8 weeks for it to, by x-ray, look as though it's healed. As a person feels better, as they have less pain, of course, they can increase their activities. They certainly don't need to be at bed rest. They're typically advised that they may be as active as they care to, depending on how sore they are or how much pain they have after surgery. Essentially, the hardware prevents them from harming what you've done by holding it internally.
Sure. And in this healing process, when the fusion is actually growing back, I read that it could take sometimes over a year for the bones to actually grow together.
That's true. We all heal at different rates, and naturally as we get older, our healing process takes longer. Also, we have to take into consideration that as we get older, particularly in women, there is the increased risk of the development of osteoporosis, or loss of calcium from the bone, that sometimes will delay or prolong the healing process. It can take as long as a year for a fusion to fully heal, depending on a person's natural physiology or biology.
All right. So, in your experience now, how many years have you been doing this particular surgery?
I've been doing variations of image-guided surgery since the mid-1980s. Certainly the Orem device, which is the latest device, has been out for about 10 years. When I was at Tulane University, we were some of the pioneers in using the device and developing protocols and procedures. So I've been using this particular device for over 10 years. I've been doing navigated spine surgery, though, for probably 20 to 25 years.
And we see that in the literature now, this is in some areas called the standard of care, which means that this is the type of technology and procedure that is most recommended for these problems? While spinal surgery and spinal fusions can be performed either without hardware or without spinal navigation, I think it is becoming the state of the art. Certainly, my personal belief is that a patient is at a disadvantage if the surgeon does not have this type of technology available for the patient's surgery. And not every facility has this high-tech equipment, but you are working with this equipment now. I know you perform a lot of your cases at OMC North Shore. Is that right?
That's true. That's true. It's an expensive piece of equipment that a hospital has to consider with regards to purchasing it. But when considering the safety, increased safety margin, shorter operative times, less complications, certainly it's a worthwhile investment.
About how many of these do you do a week, Dr. Butler?
I do 1 or 2 of these a week, probably 100 to 150 per year. So I've had a lot of experience doing this type of surgery.
Safe to say that you are one of our area experts in image-guided orthopedic surgery.
I would agree. Really, there's no one in this area that's had more experience doing this type of surgery than myself.
Well, we're delighted to have you here today, educating us on this very amazing technology and how it's helping people recover faster and a safer surgery. You can reach Dr. Butler. He works out of the SMH Founders Building in Slidell, Louisiana, and his telephone number is on the screen, 985-646-3662. Dr. Butler, from all of us at HealthQuest, we thank you for educating us today on orthopedic navigation spinal surgery. Let's try to spit that out real fast. And we hope that you'll join us again to talk about even more exciting procedures. From all of us at HealthQuest, we thank you for joining us today. Have a healthy day.